Morning, ladies and gentlemen. This is Environmental Emergencies. This should be Thursday, May the 16th. And we're on Chapter 16, Heat and Cold Related Emergencies. You should have read over Chapter 16 from yesterday. Yesterday was the day that we had for your scenario practice day. Today, after this lecture, I'm expecting you guys to look at page 111 through 116 and do questions 1 through 26. The odd questions only, please. That's not in the plans, but do the odd questions only. And read over Chapter 17, Bites and Stings, for Monday Tuesday, when we get back after the long weekend here. So, environmental emergencies. This is a long PowerPoint. I'm going to give you the abridged version, and here we go. This is Chapter 16, Heat and Cold Related or Environmental Emergencies. So essentially, the human body strives to maintain a constant temperature, and that temperature is 37 degrees below that or above that in any significant direction, and our body does not like it. We are very, very delicate creatures. We need that temperature to be appropriate for us. Body heat is generated from metabolism, breaking down of glucose into energy, ATP, in the mitochondria, breaking it down to be burned up by the muscles and other body functions. To release that heat during activity, exercise, and eventually shivering with our body reacts to cold temperatures. Normal body temperature orally is 37 degrees or 98.6 Fahrenheit. Heat always moves from a warmer area to cooler area, and this migration of heat always, when we're in a cold area like it is in northern Alberta here, we're always losing heat. The body counteracts this normal heat loss by producing more heat. If your body temperature drops down, shivering takes place. Two conditions of over or underheating. First one is hyperthermia, overheating, higher than normal core temperature. The amount of heat gained is greater than the amount of heat given off. So in other words, you're in an environment that is warmer than your body, and your body is gaining temperature from that environment. Hypothermia is the opposite direction. It's lower than normal core body temperature, so lower than 37 degrees. The amount of heat gained is less than the amount of heat given off. We as people that live in northern Alberta should know all about this. Now, the cooling of the body. When the core temperature increases, the body tries to remove heat from the surface of the skin by dilating blood vessels close to the skin. That's why we get flushed, pinking up, or the reddening of the skin. When the air temperature is warm, dilation is less effective and sweating increases. So we move fluid through sweat glands to the surface of our skin to encourage evaporation. The action of evaporation, or turning of liquid into gas of the water on our surface, absorbs lots of energy. Now, as the environment changes, sweating becomes less and less effective. Evaporation cools the body. Humidity, relative humidity as it's reported, if it's greater than 70%, sweat does not evaporate as quickly, and it causes the core body temperature to increase because our primary cooling system or our air conditioning for our body is not as effective. The body gives off heat in 5 ways: through breathing, and you'll notice this very easily when you're out in the wintertime. Conduction, if we touch something that's cooler than our body, heat moves from our body to that cool thing. Convection, this is the movement through air. Evaporation of the water from our surface of our skin takes energy from our skin, and we lose it. And then radiation, we're constantly giving off heat as infrared energy. So there's conduction, lying on something, convection, wind blowing across this, evaporation, and radiation. So the physiology of warming the body. When the body reacts to cold temperature environments to maintain core temperature, blood vessels close to the skin constrict, so we end up getting paler, and actually your dexterity to your hands, or your ability to do fine motor skills, is impaired to some degree when you're becoming hypothermic. Less warm core blood is circulated near the skin, so heat is retained at the core. The extremities can be damaged from reduced blood flow if it's an extreme situation. Shivering of the body generates heat with the involuntary contraction and relaxation of skeletal muscles. Physical activity increases metabolic action to increase heat production. So the old adage of jumping up and down or running around when you're cold does increase the amount of heat energy your body produces, warming the core. Ambient temperature. This is the external temperature of the environment. It's affected by environmental conditions. So ambient temperature is essentially our room temperature, or the temperature where you're at. Wind chill is ambient temperature, and the effect of that temperature is magnified by the action of the wind. It suggests what environment actually feels like. So we all know what the wind chill factor is. The real factor is measured in watts per square meter. We typically say it's -30 with a -35 wind chill. That's a common adage that we can understand. If I said it was -30 with a 1500 watts per square meter wind chill, you'd look at me sideways. That's the technical measurement of it. But humidity, this is the amount of moisture that's in the air, and high humidity hinders evaporation of sweat. It's called relative humidity in comparison to 100% saturation, where the air can no longer hold any more moisture. Typically in the wintertime, it's around 35 to 42% humidity in the air. In the summertime, it can get upwards of 70 or 80% when it's really hot and humid out. Now, generalized cold exposure, factors that predispose a patient to hypothermia. Young or old patients are more prone to hypothermia, because the young patients don't have the body mass to surface area ratio. They can't produce adequate amounts of body heat. And older patients, their body functions are slowing down and they are not able to produce adequate amounts of heat either. Medical condition, if you have a predisposed medical condition, i.e. you're a burn patient, or older people, geriatric considerations we talked about the other day, they are all more predisposed to cold exposure. Immersion or submersion, if you've been in the water, you're definitely going to lose heat a lot faster if you're in cold clothes or wet clothes, sorry, and the water will absorb heat from you very, very quickly. Alcohol and drug use, this also impairs our body's ability to accommodate or change to meet the needs of the, or change to meet the environment that we're in, okay? It also dulls our perception of the cold and heat as well. Now, signs and symptoms of generalized cold exposure, speech becomes difficult, poor communication, stiff, rigid posture, low or absent blood pressure, poor judgment, memory disturbances, mood changes, reduced sense of touch, poor coordination, muscle stiffness, and cool abdominal skin. Now, this is a fairly extreme case when you get into these situations, okay? Vital signs change, altered level of consciousness, confusion level to coma, rapid breathing early, becoming shallow or non-existent in late stages. The person is slowing right down. A rapid pulse beginning to slow and then becoming absent, blood pressure typically low to absent, shivering stops, and body temperature drops quicker. When shivering stops, you know that the person's body's compensatory mechanisms are failing and the body is saying, okay, we're too cold, shut down, we got to save energy. Shunt blood to the core, away from those skeletal muscles. Muscles stiffen, pupils dilate and become sluggish. The person is in a world of hurt. To avoid this or to treat the patient, first of all, we need to wear personal protective equipment that addresses the weather that we're going to be working in. We need to remove the patient from the cold environment if we can. We need to protect the patient from further heat loss. Consider possible injuries during the move. You want to treat a patient that is hypothermic very, very gently. Handle the patient gently, because sudden bumping or jerking movements with a patient that is very, very cold at the core can actually send the heart into a dysrhythmia. Do not let the patient exert themselves or walk, transport them yourself. Remove all wet clothing, and that means all. I've been in this situation, and I mean they cut your underwear off in the hospital. They did not let you have anything on. Cover the patient to help retain any body heat they have remaining. Administer high concentration oxygen. There's your 10 to 15 liters a minute via non-rebreather. If we've got warm humidified oxygen, administer that. Turn up the heat in the patient compartment. Do not massage the patient's extremities. You can actively warm them with warm blankets. You can apply heat packs in the groin, axillary, and cervical regions. These areas have a lot of blood flow, therefore they can lose heat, but they can also gain heat in those areas as well. In the emergency room, they will start large bore IVs and put warmed intravenous fluid into the body as well as using warmed blankets from a heater. Patients that are unresponsive or non-alert patients, we need to passively rewarm them with blankets. Do not give anything by mouth. Assess their pulse for a full 60 seconds before initiating CPR, because they may be so hypothermic, their heart and all functions may be really, really, really slowed down. Pulse and respirations may be difficult to detect. A slow heart rate is very common. There is a saying that you're not dead until you're warm and dead. Hypothermic patients are never called until they are warm and dead. There are situations, we have one locally where a small child was immersed for a period of time. They worked her for, I think, an hour and a half before they warmed her up and they got a pulse back. So last I heard, she was in the stallery, recovering. Don't know any word about deficits or anything, but as her body warmed up, it then responded to CPR and they got a pulse back. With unresponsive patients, if there is no pulse detected, apply the AED and follow local protocols. Be careful with them again because rough handling can cause ventricular fibrillation. With patients that are hypothermic, it's one shock and one shock only. We don't do shocks after every 2 minutes of CPR. One shock only. The core temperature may affect defibrillation. It may not be effective until we get that core temperature up. So we do that, we transport, we turn them over to the hospital. The hospital will continue to do their job. Injuries tend to be limited to areas that are unprotected, poorly protected, or are wet. Most oftentimes involve skin surfaces of the ears, nose, face, or distal extremities like fingers and toes. Sorry, just had to hit the wrong button here. We've all had minor frostbite on our hands and so on with distal appendages. Superficial frostbite, different levels of cold emergencies. Frostbite, we've all had this, also called frost nip. Involves top layers of the skin characterized by discoloration and loss of sensation. Assessment may reveal clear demarcation or visible lines of color change where the surface layers of the skin are partially frozen. Involves skin blanching, i.e. there's essentially a whitening of the skin. There's no blood in it. Essentially, you want to rewarm these areas. Have a patient blow warm air on the affected part. When rewarming, patient may notice pins and needles and tingling sensation, and I think most of us in Northern Alberta have felt that as well when we came in from playing outside for just a little bit longer than we should have. More serious than frost nip is deeper frostbite. Usually occurs from longer exposure to the skin and involves freezing of the deeper layers of skin. Skin becomes discolored white and waxy from lack of circulation. And essentially, if you think about it, if the cells are frozen, there are ice crystals in the cells, and those ice crystals are sharp, and they're penetrating the cell walls, and they're damaging the cell walls. Okay, the skin feels firm to hard or frozen on palpation. Gross swelling of the area or fluid-filled blisters may also be present. Blisters will form on frozen tissue as well as burnt tissue. If thawed or partially thawed, skin may appear cyanotic or flushed. Here's an example picture of a deep frostbite on the feet, and you can see these blisters almost make it look like a burn rather than a frostbite injury. This is 24 hours after the injury occurred. Here are some more swelling and deformities with some blistering on the hands of a frostbite patient as well. And here are some toes, deep frostbite. The blackening of the tissue indicates tissue necrosis. That necrosis is the death of the tissue. Like I said before, the growth of ice crystals within the cells destroys the cell walls, causes the cell walls to break and rupture, and essentially kills those cells. So like a burn, it destroys the skin. Here's some very deep frostbite. This is 6 weeks after a frostbite injury, and that's essentially the underlying tissues, bone. You can see the foot is all worn away. This is nasty stuff. This is gangrenous necrosis. So in other words, they have gangrene. They're going to lose both feet if they don't lose their life. When you're dealing with deep frostbite patients, you want to safely remove them from the cold environment, protect the uninjured tissue from further injury, protect the injured tissue from further injury, administer oxygen high flow. Remove wet or restrictive clothing to allow blood circulation. Remove all jewelry because they are going to swell, and that jewelry can restrict blood flow. Cover the entire area with dry clothing or dressings to retain heat. Splint and cover the extremity if involved. Do not re-expose them to cold. Do not rub or massage the affected area. It can actually damage the tissues. Don't break any blisters. Don't pack the affected area with snow. It's an old wives' tale. Do not apply direct heat. It can cause a tissue damage as well. Do not allow the patient to walk or use the affected extremity. It can do more damage to the tissues. Do not rewarm patient unless following prescribed guidelines. If you cannot guarantee that the patient will not refreeze that appendage, do not warm it. When you defrost it and then allow it to freeze again, the damage to the tissue will be exponentially worse. Do place dressings between the affected fingers and toes so they don't stick together. Do not thaw the area if it's rephrasing is likely, like I just said. Expect the patient to complain of pain because it is going to be painful. Essentially, they're going to activate the same nerve endings, sorry, as a burn will. Provide emotional support as needed. So this is a fairly extensive bandaging activity. This will take place at the hospital. You can see how they've got the toes separated and so on. After removing affected extremity from the cold, place a dry sterile dressing over the area. Place dressings between the fingers and toes if affected as well. So the opposite end of the spectrum with heat exposure. Environmental factors that lead to heat exposure. High ambient temperatures reduce the ability to lose heat by radiation. High relative humidity reduces the ability to lose heat through evaporation. So if we're in a very hot area that has high humidity, we're already predisposed to heat injuries. High humidity or moist heat cause people to tire quickly because our body cannot cool down via the prime cooling mechanism, which is evaporation of sweat. Just hold on for a quick second here. I have to pause you. Okay, so high humidity can cause people to tire very quickly because our primary mechanism for cooling is impaired. The body can lose more than a liter of fluid of sweat per hour trying to cool off. Fluid loss involves elimination of electrolytes as well, and they affect our body's ability to transmit electrical signals via the central nervous system and peripheral nervous system. Predisposing factors to heat exposure: age, again, very old or very young patients are very susceptible. Current and past medical conditions, medications, reactions to any previous heat exposure can cause a predisposition towards it. Pre-existing conditions such as dehydration, obesity, fever, fatigue, diabetes, any other disease that involves the circulatory system, the kidneys, etc. Signs and symptoms of heat exposure, varying degrees. Again, dizziness, muscle cramps, moist, pale skin, altered mental state, unresponsiveness, cool skin temperature, weakness, exhaustion. There may be some visual disturbances and so on. I know when I get dehydrated and getting close to heat stress, things seem a little hazy, almost like ringing in my ears and so on. So you want to note any obvious signs during your scene size up. Where are they working? What activities were they doing? This is one that ACP loves to use for your scenarios. I remember doing this one twice. One was a person that was along a parade route that was in a mascot costume for a parade when it was 30 degrees outside, and they were dry because their body quit sweating, and they had a heat related emergency. Another one was they worked in an industrial shop where it was very, very hot. There was no breeze or anything like that, and they overheated in that state here. Working in a room with high temperature, a hot day with high humidity, working in direct sunlight, and so on too. You know, students that are playing sports, football, rugby, soccer during the summer are also susceptible to this. So heat cramps, this is the first level, the most, I guess, the least serious. Muscle cramps usually limited to the patient's legs and abdominal area. It's essentially associated with prolonged exposure to a warm environment and dehydration. With heat cramps, the patient sweats and usually consumes large quantities of water. As sweating continues, water and salts are lost from the body, causing painful muscle cramps. Now, sodium is one of the primary components of salt, and sodium is sodium, potassium, and calcium are essential to muscle contraction. So if you're outside exercising lots, you're utilizing a lot of sodium in the contraction and relaxation of muscles, the transmission of those nerve signals down to those muscles. And if you're sweating out a lot of these salts, a lot of that is lost and you need to replenish it. Patients may complain of dizziness, exhaustion, faintness. Consumption of sport drinks are an activity that can preempt this from developing these heat cramps. But in consumption of those sport drinks without actually engaging in sports can also be detrimental and potentially cause kidney stones and things like that with too much electrolyte being taken in and not enough lost. Next thing, heat exhaustion, next level. Failure of the circulatory system to adequately maintain normal function due to a loss of fluids and salt. In other words, it's hypovolemia. So there's a problem with the blood. You don't have enough of it. You're sweating it out. in the form of sweat. Occurs after long, prolonged activities in a warm environment without adequate fluid intake. Signs and symptoms include cold, clammy, pale skin, heavy perspiration, total body weakness, dizziness, or altered LOC. So the person's compensatory mechanisms are still working, and they're actually what's causing the issue here. A deterioration or a decrease in blood volume due to the use of that fluid to sweat. It is the next level is heat stroke. This is a life-threatening emergency, results from a failure of the body's heat-relating mechanisms. Core temperature becomes hyperthermic. In other words, it's way over 37 degrees. Most cases occur on hot, humid days. And again, there's that bad boy humidity doesn't allow the body to adequately cool itself. Can occur indoors or outdoors. Signs and symptoms, there's deep breathing followed by periods of shallow breathing. Rapid, strong pulse followed by a rapid, weak pulse as blood pressure drops off. Dry, hot skin, maybe red or flushed in color, dilated pupils, loss of consciousness, muscle twitching, or seizures. Our brain is mainly fat. It has a lot of myelination on the fibers, and fat, as you know, melts when it gets hot. Our body does not like hot temperatures. It will send our body into seizures. A case of what's called febrile seizures occurs in small children and infants when they have fevers. And that's as a result of the brain short-circuiting because of the high temperature. When you're dealing with these patients, you want to remove them from the hot environment and place in a cool area immediately. Loosen or remove their clothing to allow the perspiration that is on their body to evaporate. Manually fan the patient. Move some air across them. Elevate the legs to assist with circulation. Placing them in what's called the Trendelenburg position, lying on their back with their legs elevated, allows gravity to pull more blood into circulation. Administer oxygen, of course. Place the unresponsive or vomiting patient in the recovery position, and to pack to the oxygen here, 10 to 15 liters, non-rebreather. If submersion is included in local protocol, fully protect the patient. What this means is to place them in a bath. It is not appropriate in our local protocol. A sponge bath or putting water on their head with a cloth on it can be done here. Drowning. Okay, this is a water-related emergency. From this point on this presentation, it's dealing with other environmental issues. Our heat and cold-related emergencies is essentially where I wanted to stop off here. That's about 22 minutes, 23 minutes. That's enough of that. So what I'd like you guys to do now is have a look at page 111 through 116. Do questions 1 to 26, odd questions only once again. Then have a look at chapter 17, bites and stings. That chapter 17 starts on page 251. We'll talk to you guys on Monday.